Hi, my name is Liang Liu, and I'm the Ultrasound Fellowship Director at Emory University. Today's talk is an introduction to soft tissue ultrasound. Now, when we see a patient who presents with something like this, there is often no question that this is a soft tissue infection. This is often where ultrasound may not really be necessary, especially if on exam we can tell that this is isolated, superficial, and not associated with any systemic symptoms. However, in a patient that presents with something like this, we may have more questions. These two patient presentations spans the potential of soft tissue infections, something very simple versus something that makes you pause and say, wait a minute, what is that? When it comes to point-of-care ultrasound accuracy in diagnosing soft tissue infections and abscesses specifically, there has been a number of studies, including those shown in this table, courtesy of Dr. Avila. In this table, white values demonstrate sensitivity and specificity of physical exams, while blue demonstrates that with ultrasound. You can see that while specificity is mostly comparable between the two, sensitivity increases with the use of ultrasound. Most of these studies were small sample sizes, so in 2020, Gottlieb et al. Completed a systematic review and meta-analysis to determine the diagnostic accuracy of point-of-care ultrasound for identifying skin and soft tissue abscesses. They also looked at whether point-of-care ultrasound resulted in a change in management and the difference in failure rates between point-of-care ultrasound and non-ultrasound patient groups. As you can see from this data, point-of-care ultrasound has good diagnostic accuracy for differentiating abscesses from cellulitis. They also did subgroup analysis, which showed that these values were better in adults and also better in those with high clinical certainty, which makes sense. Additionally, these authors concluded that point-of-care ultrasound led to a correct change in management in about 10% of cases. It is important to note, though, when looking at point-of-care ultrasound impact on treatment failures, the pooled odds ratio does cross 1. Another useful study by Gaspari et al. Is a randomized controlled trial that looked at outcomes of abscess INDs in patients who received and did not receive point-of-care ultrasounds. Stable patients who presented to a single site with a suspected skin abscess requiring incision and drainage were eligible. 125 patients were enrolled, in which 13 were lost to follow-up. The remaining 107 patients were followed. Of the patients enrolled and not lost to follow-up, 11 patients had failure of therapy, defined as pain and fluctuance requiring return to the ED. 9 in the physical exam only arm and 2 in the ultrasound arm. The study noted that patients with an abscess who were undergoing incision and drainage without ultrasound were more likely to fail therapy and have repeated incision and drainage compared with those undergoing incision and drainage with point-of-care ultrasound. I encourage you to refer back to these studies to learn more about the details. Now that we've discussed the benefits of soft tissue ultrasound, I'd like to jump into how to do this. For this exam, in general, you will use a high-frequency linear probe for better image resolution. However, depending on the depth of soft tissue, you may need to switch to the curvilinear or lower frequency probe for better penetration of deeper structures or a larger field of view because of its large footprint. To help you visualize what you need, there are a number of tools at your disposal. First is just lots of gel to try to maintain contact of the probe. If this is difficult, you can also use a water bath or a standoff pad. Here are a few examples of water baths and standoff pads. Here, these standoff pads are saline bags, a glove full of fluids. You can use a water bath in the traditional sense of a basin. You can also even use an emesis bag. And as you can see here, fill that emesis bag and then place the extremity within the bag. Water helps improve your probe contact and provides a nice acoustic interface to see structures, specifically when they are not smooth. Note that the probe in a water bath does not need to contact the skin because you are actually maintaining that contact with the fluid itself. This is great for imaging hands and feet and also helpful with kids. You can also use Doppler, which can help to identify inflammatory conditions associated with increased vascularity or inflammatory reactions. This video just further highlights the benefits of a standoff pad. In addition to better probe contact, you can also see that soft tissue a few millimeters from the surface is better imaged by the ultrasound. As for technique, start in an unaffected area and then slide your probe to an affected area. First, appreciate what normal anatomy is and then look at abnormal anatomy. Make sure that you scan systematically in two orthogonal planes as seeing two views will help you better identify spatially what's going on with the structures. The other nice thing is that if you're looking at an extremity, there's usually a contralateral extremity that you can compare it to. Here's an example of normal tissue and some of the highlighted tissue layers. You have at the top epidermis dermal layer, then the subcutaneous tissue, the hyperechoic fascial tissue, and then the muscle bellies, which are striated. Note how distinct each tissue layer is. When evaluating for infection, ultrasound can really help you distinguish not only the presence of a fluid pocket, but also where and how deep that fluid pocket extends. With ultrasound, you can distinguish cellulitis and subcutaneous abscess as compared to pyomyositis and intramuscular abscesses. Additionally, you can see the fascial layers nicely in this normal tissue. In later talks, we will discuss how this helps us evaluate for necrotizing soft tissue infections where there could be a fluid pocket running along the fascial plane. Here's another example of normal in a patient with more subcutaneous tissue. Again, you can see the distinct muscle layer, the fascial tissue, and subcutaneous tissue very clearly. The very first sign of an infection is actually not cobblestoning, but distortion of our architecture. With very early edema, you will just note that the tissue no longer looks as clean and clear as another area that may be more normal. As you look at this image, for example, we don't see the nice subcutaneous layer, the fascial layers, any of that as well. As vessels become more permeable, more fluid will spill and you will see something like this. This is cobblestoning. This is a cobblestone-like appearance that's composed of hyperechoic, hyperemic pattern of the inflamed subcutaneous fat intersecting by anechoic fluid along the connective tissue. A cobblestone-like appearance only indicates inflamed tissue and is not specific for cellulitis. The ultrasound finding is meant to mimic that of cobblestones on an old road. Again, this is diffuse thickening of subcutaneous layer secondary to edema between fat and connective tissue. Here's another example. This is a patient who presented during cardiac arrest and had an IO infiltrate, resulting in IV fluids in their lower extremity. This is a good example of not all cobblestoning is infection. Here we are using a water bath to image a finger. You see the epidermis as a hyperechoic outer layer, the soft tissue with some distortion of architecture and cobblestoning, and the hyperechoic structure with shadowing, which is the bone. Here is a standoff pad, allowing us to image the dorsum of a hand. In addition to cobblestoning, this has a noted fluid collection consistent for an abscess and more normal tissue. You can see here that we have distortion of architecture in that abscess right there, and then as we go further, much more normal digits. Here's another example of a subcutaneous abscess. This is much larger and more apparent. And you can see around it that hyperechoic fat and soft tissue. Note how fluid collections can vary in appearance. This has almost a starry sky appearance. This abscess, perhaps older, has almost a rind to it, as if the body has already attempted to wall this off. The fluid within this abscess is actually anechoic, but when drained, it's still pus. Here, this fluid collection is concerning as it is rather deep. You can see it goes down to at least 3 centimeters, but we're not really seeing the base well. And there appears to be a likely vessel or the eye of this dinosaur, as you can see in this area here, that's very close to the fluid pocket itself. In this case, I would pause in my plan for incision and drainage and rather get additional imaging to see how deep this pocket goes. This is not a simple abscess. Just as fluctuance on physical exam is a wave-like or boggy sensation when pressing on a fluid pocket, sonographic fluctuance is a dynamic finding in which the internal contents of a fluid collection moves in response to gentle compression from an ultrasound probe. This can be seen as a ripple effect, or as you can see in this example, a squish. This is an example where you may not be able to distinguish phlegmon from abscess, and perhaps you're concerned that when you cut into this, you may not have adequate drainage. However, with ultrasound, you can confirm that indeed there is fluid within this pocket. Note though, as we have already mentioned, not all cobblestoning is infection, but rather cobblestoning just means soft tissue edema. Additionally, not all abscesses are anechoic, and not all that is anechoic is an abscess. Here is an example of an ovoid-shaped structure. It is hypoechoic compared to its surrounding tissue, and it has an echogenic hilum. Hilar vascularity can be seen, or the structure may appear avascular. This is an example of a lymph node. Here's something found in the popliteal fossa of a patient with nodus swelling. This is well-defined anechoic structure that demonstrates posterior acoustic enhancement. And if you further evaluate this, you will also see that this cyst communicates with the joint space. This is a Baker cyst. And here's a circular, well-defined anechoic structure that appears to be pulsatile. When we turn on color flow on this, we see a classic yin-yang or swirl sign due to swirling of the turbulent flow, which is seen in a pseudoaneurysm. This is actually what our patient at the beginning of this lecture had. I'm sure glad I didn't cut into that. In summary, make sure you start with normal anatomy, or if possible, compare the affected to the contralateral side. Scan systematically in two orthogonal planes to give you a better idea of the three-dimensional space of that structure. Allow patients to guide you to the area of maximal tenderness. And use your aids, plenty of gel, a standoff pad, a water bath, color flow, etc. Make sure that you don't let air get in the way of a good image. If you're not maintaining good contact, make sure that you do use a water bath or a standoff pad and do not cheat yourself from a good image. And also just always remember that not all that is anechoic or a fluid pocket is infection. With that, thank you for your attention.